Good evening, students. Welcome to you from Sri Rama Hospital, Jagaipet. We are studying about the disease of the urinary bladder. Today, let us study about the urinary fistula and cystitis and carcinoma of the bladder. What is fistula? Define fistula. Define fistula. Fistula is a tract lined by granulation tissue connecting to epithelialized surfaces. So, urinary fistula means it is a tract connecting the urinary organs with another epithelialized surfaces. The other epithelial surfaces can be skin, most commonly, or the bowel. Types of urinary fistula: congenital, patent urachus, ectopia vesicae, high-level anomalies. So in the high-level anomalies, we have seen that there are two conditions, rectal ectasia and anorectal agenesis. In these two conditions, the rectum or the colon opens into the bladder or sometimes into the urethra. The acquired types: traumatic, post-infectious, example tuberculosis, diverticulosis of the colon, post-operative; neoplastic, following neoplasms of the cervix, uterus, colon, and rectum. When these neoplasms they infiltrate the bladder or the ureter, there will be fistulas. Infections like Crohn's disease, appendicular abscess, pelvic abscess following pelvic inflammatory disease like salpingitis, or pelvic abscess following surgery, tuberculosis of the kidney, pyonephrosis, etc. These infections can cause communication between the urinary organs and the viscera or the skin. Types of urinary fistula according to the site: vesicovaginal, that means between the urinary bladder and vagina; ureterovaginal, between the ureters and the vagina; ureterocutaneous; urethral fistula, following stricture of the urethra; the ureterovaginal fistula. Usually follows surgery on uterus, ovary, or colon. So whenever these surgeries are being done, when ureter is injured, then there is sloughing of the ureter and communication of the ureter with the vagina, because these organs are quite near to the ureter. Here again I will ask you one more question. What are the places where ureter is closely related to the uterus during hysterectomy operation? What are the places where uterus is closely related to the ureter during hysterectomy operation? Very good. It is infundibulopelvic ligaments, uterine artery, and Beckenrot's ligament. These three. Okay. Ovary. Where ovary is related to the ureter. How ovary is related to the ureter. Very good. It is infundibulopelvic ligament. Very good. Then colon. Which part of the colon is related to the ureter? The sigmoid colon. The sigmoid colon. Yes, good. Treatment of ureterovaginal fistula. You have to reimplant the ureter into the bladder after a psoas hitch or Boyer's flap. I hope all of you know about Boyer's flap. Then vesicovaginal fistula. Here I am just mentioning briefly about vesicovaginal fistula. This is a very important topic for you in your gynecology examination. So you can go through your gynecology textbook for the details. But here I just am giving a bird's eye view of the vesicovaginal fistula. Causes: obstetrics, neglected labor. Tell me how neglected labor causes VVF. I hope you know that the uterus, vagina are situated posterior to the urinary bladder. During labor, when there is cephalopelvic disproportion is there, when the head of the fetus is large, and when there is difficult labor is there. So what will happen? The lower segment of the uterus will now have the head of the fetus. The uterus is pressing it or squeezing it down. Now what happens? The head of the fetus will be pressed against the symphysis pubis because the inlet of the pelvic inlet is narrow. So the head of the fetus will be pressing the wall of the vagina as well as the urinary bladder against symphysis pubis. So between two hard surfaces, these two viscera are compressed. If this is neglected, this is for more number of minutes is there, then what will happen? There will be irreversible damage to the vaginal wall and urinary bladder wall. Both of them slough at the same place. And after delivery, during 5th day to 15th day, these sloughed areas, they will separate. And a communication develops between the urinary bladder and anterior wall of the vagina. This is called the vesicovaginal fistula. This is one of the commonest causes of vesicovaginal fistula. It is not due to perineal tears. It is due to only cephalopelvic disproportion where the head of the fetus causes compression against the pubis, pubic bone. So between the head of the fetus and pubic bone, the anterior vaginal wall and the urinary bladder, they get compressed. And due to compression, there will be ischemic necrosis. This ischemic necrosis leads to vesicovaginal fistula. This is one of the commonest causes of vesicovaginal fistula. Then gynecological causes like hysterectomy operation and anterior colporrhea operation. In hysterectomy operation, We have to separate the cervix from urinary bladder, and the anterior fornix of the vagina also has to be separate from urinary bladder. During this procedure, sometimes you may injure the bladder. Thereby, the vesicovaginal fistula can develop. Anterior colporrhaphy is done in case of cystocele, either plain or cystocele associated with uterine prolapse. Then following radiotherapy to the carcinoma cervix. The neoplastic infiltration from cervical cancer. So these are the common causes. The investigations: three swab test. This is the three swab test. What you do is you ask the patient to empty the bladder, then keep three swabs in the vagina. That means the total vagina is filled with these three swabs. Then what you do is you pass a catheter into the bladder and instill methylene blue solution into the bladder. So now the urine in the bladder is stained methylene blue. Then remove the catheter, ask the patient to walk for about 5 minutes. Then again ask her to lie down on the couch and then remove the three swabs and look at them. If the middle swab is stained blue, the upper one and lower one are dry, or the uppermost swab is stained blue, that means it is vesicovaginal fistula. Uppermost swab, only wetting is there, that means it was wet with urine but not discolored, means it is ureterovaginal fistula. Discoloration of the lowermost swab but upper two swabs remain dry, means it is ureterovaginal fistula. So this is called the three swab test. So the three swab test will tell you whether the communication to the vagina is between the bladder or the ureter. Then you do cystoscopy and retrograde ureterography to evaluate the size of the fistula and place of the fistula in relation to the bladder, whether it is near the trigone or in the dome of the bladder. Treatment: repair by vaginal or abdominal route. So I am not giving details here. Okay, here, dear students, it seems Srutiga is getting disconnected frequently. So are you getting the same problem, or are able to see the video streaming as well as audio streaming without any interruption? If you have any problem, if you too have any problem, we will. No problem. Okay. No interruption. Very good. Then, Sruti, you please refresh your page once. Refresh your web page. Then it will be settled. Because the other students are having no problem. You have the problem, so you please refresh your web page. That will correct it. Okay. Now, neoplasms of the bladder. Classification: benign neoplasm is the okay, Shruti, I will do one thing. After I finish the class, the first few slides, that means the fistula slides, I will show you again. Don't worry. So please remind me at the end of the class. So here, the classification of neoplasms of the bladder being benign tumors, that is the transitional cell papilloma. The malignant, Primary, it is transitional carcinoma. Squamous cell carcinoma, this bladder has transitional cells, but it may develop squamous cell carcinoma from an area of metaplasia or biliary. Then adenocarcinoma from urachal remnants. We have seen the urachus. So the urachus is having glandular structure. That is why from the dome of the bladder where urachus arises, the adenocarcinoma can occur. Sarcoma of the bladder, of course, it is rare. Then secondaries in the bladder. Invasion from local adjacent organs like colon, ovary, renal, prostate, or uterine growths. Or it may be implanted through transcoelomic spread from stomach, colon, rectum, lung, prostate due to intracoelomic spread. Transit cell papilloma. It is most probably a low-grade variant of a malignant papilloma. It may be single or multiple. It has a frond with a central vascular core and multiple tufts and villi. You can see a typical papilloma here. Carcinoma of the bladder. Etiology, industrial or occupational causes. Prolonged exposure to certain chemicals in various industries dealing with textiles, rubber, dyes, leather, and certain chemicals. Occupations like painters, sewage workers, and petrol workers. These are all the carcinogenic chemicals. Then genetic causes. It is reported in some families. Smoking, biliary. Pathology, gross appearance. There are three types. Villous tumors. They appear like papillomas but have stunted villi, sessile and vascular base, ulceration over the surface, are associated with cystitis. Then solid tumors. Solid mass in the bladder are always malignant. These are second commonest malignant tumors of the bladder. Secondaries in the bladder are the commonest bladder tumors. They are sessile, polypoidal, or lobulated with phosphate encrustation. Later they get ulcerated and bleed on touch. These tumors spread rapidly than villous tumors. Then malignant ulcer, this has features of a typical carcinomatous ulcer. This is the most malignant tumor of the bladder. Spread of these tumors locally through the bladder wall. Lymphatic spread into the nodes along the iliac vessels. Blood spread occurs late into the lungs, liver, bones, or brain. Clinical features, painless hematuria. So hematuria in an elderly patient should always be investigated. If it is painful, we will think of either infection or a calculus. If it is painless, it may be a benign or malignant neoplasm. It is intermittent in the beginning and later becomes continuous. The other clinical manifestation is retention of urine. If the growth is situated over at or near the internal urethral meatus, there can be retention of urine. Then severe or recurrent cystitis. Sometimes it can manifest as hydronephrosis when the growth involves the ureteric orifice. There may be pain in the suprapubic region if the growth infiltrates the muscle wall of the bladder. Pain refer to the suprapubic area, groins, perineum, anus, or thighs when there is extra vesicle spread. Staging TA, tumor confined to mucosa not involving the lamina propria. That means it is an in situ cancer. T1 means tumor involving subepithelial tissues only, including the lamina propria. T2, infiltration of the muscle. T3, full thickness of the muscle and extravesical spread. T4, tumor fixed to the adjoining structures like pelvic wall or prostate. So depending upon the intramural spread, the tumor is staged. This T-staging is assessed by bimanual palpation under general anesthesia, one finger in the rectum or in the females, in the vagina, and another hand on the abdominal wall. So between the two hands, the bladder tumor is palpated and assessed for its thickness. By that, for thickness and mobility. By these two features, you will be able to assess the level of infiltration. If it is a papillary tumor, it is designated as small p T lesions. There's PTA, PT1, PT2, PT3, PT4, like that. Investigations, urine analysis, microscopic examination for RBC, malignant cells on exfoliative cytology. Plain X-ray abdomen may reveal calcifications. Intravenous pyelography, the hydronephrosis, if it is there, you can be able to see it. There may be filling defect during cystogram phase. You can see this IVP. There is hydronephrosis on the right side. And this is the bladder. So the lower part of the bladder, you can see there is a filling defect. So there is a mass here that's causing the filling defect, and the same mass is causing obstruction to the ureter, producing hydronephrosis. You can see this is a cystogram phase. Of course, ureters are not yet dilated. This is cystogram phase. You can see an irregular filling defect in the bladder. Again, you can see here there is hydronephrosis. The ureters are not delineated here, but you can see in the bladder there are two filling defects. One filling defect is here, and another filling defect is here. No, it is due to hydronephrosis, is due to the obstruction to the ureteric orifice. Sometimes the ureter may not be demonstrated, but because there is a lot of urine here. Hydronephrosis means it is aseptic dilatation with accumulation of urine. So the dye is diluted. So diluted dye, if there is a lot of urine in this ureter, then the ureter is not seen. But if you take a film after 2 hours or 3 hours, then you will be able to see the ureters also in this case. So in early film, the ureters may not be able to be demonstrated. Cystourethropy is the investigation of choice in all suspected bladder tumors, because with cystoscopy you can visualize the tumor, and if any suspected lesion is there in the bladder, you can take biopsy. CT scan will help you to evaluate the tumor infiltration and lymph nodal presence, as well as metastasis in the liver. Treatment, it depends on the stage of the disease and nature of the disease. Non-invasive tumors, that means tumors which have not infiltrated the muscle wall. that is TA and T1 tumor. You can do endoscopic dissection of the tumor along with the base with a resectoscope. That means it is a cystoscope. The cystoscope is fitted with a loop which is connected to a bipolar diathermy. So with the help of the bipolar diathermy, you will cut through the around the lesion, and the mucosa with the lesion is separated from the underlying muscle wall and it is removed. So with the help of endoscopy, the dissection can be done. The base is examined histologically for invasion of the lamina propria. If lamina propria is infiltrated, then you have to go for a total cystectomy, or you can give intravesical chemotherapy with mitomycin C. The invasive tumors, that is T2 and T3 tumors, the procedure adopted is controversial. Primary surgery alone or radical radiotherapy or a combination. Surgery means it is radical cystectomy and pelvic lymphadenectomy followed by diversion of urine. That means you remove the bladder along with its fascia and along with the iliac lymph nodes. So then how the urine will be stored? You do a procedure called urinary diversion. So just a few slides later, I will explain to you how urinary diversion is done. For small adenocarcinomas, you can do partial cystectomy. From the urachal remnants, sometimes in the dome of the bladder, there can be the adenocarcinomas. Radiotherapy. External radiotherapy is given as an adjuvant therapy or as a sole therapy. Systemic chemotherapy. Doxorubicin, vinblastine, cisplatin, methotrexate. So these are the drugs that are administered for systemic chemotherapy. For T4 lesions where the tumor has infiltrated the pelvic wall, you have to go for only urinary diversion and palliative radiotherapy or chemotherapy. That is about carcinoma of the bladder. Urinary diversion. That means the normal passage of the urine is being diverted to some other route. So where you do this? After cystectomy, where there is no bladder, you cannot anastomose the ureters to the urethra directly. That is why the urine has to be diverted to some other structure to get evacuated. So cystectomy, irreparable bladder outflow obstruction. So whenever there is an obstruction below the bladder neck, which cannot be repaired. Incurable fistulas. Loss of sphincter mechanism. So whenever the sphincters are being damaged, the urethral sphincters, there will be continuous leakage of urine. So there will be complete incontinence. So in such condition, the patient needs urinary diversion to keep him dry. So methods of urinary diversion. Diversion from the kidney. So whenever there is a need to divert the urine from the kidney, the methods. Pilostomy. In ectopia vesicae, usually you do repair operation. Before repair gets achieved, then you can do preliminary urinary diversion of the ureters. You can divert the ureters. Yes. The diversion procedures for the augmentation cystoplasty and diversion are not the same, because in augmentation cystoplasty, you are achieving the normal route, but bladder is being getting enhanced in its capacity. Urinary diversion means the normal route is being diverted. It will not come through the urethra. The urine will come out through some other route. That is urinary diversion. You can see here kidney diversion. Do pilostomy. That means you pass a catheter into the pelvis or the kidney. The catheter is passed directly through the kidney into the pelvis. We call it as nephrostomy. Then ureter, as you have said, ectopia vesicae, or following cystectomy operation. So how the ureters will be diverted? You can get the ureters, and each one of them can be anastomosed to the skin, just like ileostomy. You do the ureterostomy, and you provide a bag there. So the urine will be collected in the bag. Either two separate orifices can be made, or you can anastomose those two ureters and make a single opening, and single opening can be anastomosed to the skin. Or the third procedure is you can anastomose the ureters into the sigmoid colon. Then what will happen? Sigmoid colon will be filled with urine, and rectum will be filled with urine. So once they get filled with urine, patient gets sensation of defecation. So then he goes to the toilet and then evacuates, just like stool evacuation, the urine also outside. And the feces also will be coming to the same route. Because feces also is coming here, the fecal bacteria can enter into these ureters and can cause pyelonephritis. So to avoid this problem, you can modify this procedure. You can do colostomy for fecal drainage and then use the rectum for bladder drainage. This is called rectal bladder. Or you can anastomose the ureters into a segment of ileum, and this ileum is anastomosed to the skin doing ileostomy operation. So here the ureters are anastomosed to the ileum, and ileum is anastomosed to the skin. Ureters cannot be anastomosed to the urethra. That is number one technical difficulty. So because there is prostate gland is there, it is difficult to do anastomosis to the prostate gland. So ureter diversion, you can do a cutaneous ureterostomy, you can do a ureterosigmoidostomy, either in continuity like this or separate rectal bladder with colostomy. Then you can also make a ileal conduit for delivery of the urine outside through ileostomy. Then bladder diversion through suprapubic cystostomy. That means you pass a catheter into the bladder through the skin. Cutaneous vesicostomy. That means you anastomose the bladder to the skin. Complications of these operations: stricture development at the site of operation. There can be reflux producing pyelonephritis. Then there may be absorption of salts. For example, if you do ureterosigmoidostomy operation, the property of colon is absorption of water and electrolytes. Urine contains a lot of electrolytes which are not necessary for the body. So these electrolytes, they are secreted through the ureters and they are being collected into the sigmoid colon because you have done surgery to the sigmoid colon. So then what happens? The salts are being absorbed. So usually the chlorides are more absorbed, and that leads to hyperchloremia. Already we have seen whenever there is hyperchloremia, there will be acidosis. So this is about the urinary diversion. This last point, reabsorption of salts producing hyperchloremic acidosis, is one of the frequently asked questions in the PG entrance examination. What is the biochemical abnormality produced after ureterosigmoidostomy or diversion of urine into the sigmoid colon? So that is the question. So the commonest biochemical abnormality is hyperchloremic acidosis. So with this we we complete the topic of urinary bladder. Now we'll go to the disease of the prostate. Anatomy of prostate. Prostate is situated below the bladder neck, enclosing the upper part of the urethra. You can see this is the urinary bladder and this is the prostate gland. On its posterior side, you can see the vas deferens and seminal vesicles. They join together to form the ejaculatory ducts. The ejaculatory ducts, they pass through the posterior surface of the prostate gland. It is a triangular shaped structure. The base is towards the bladder and apex is situated on the perineal ligament. So this is the prostate gland. The base is related to the neck of the urinary bladder. The ejaculatory ducts, they travel through the prostate gland to open into the posterior side of the prostatic urethra. Anteriorly, it is separated by the pubic bone and it is bound to the pubic bone by puboprostatic ligaments. Posteriorly, it is related to the lower one-third of the rectum. Of course, this is the sectioning of the prostate gland, shows the prostatic urethra here. And in this prostatic urethra, you can notice here the prostatic utricle. Then you can see the openings of the ejaculatory ducts just below the prostatic utricle. And the posterior wall, you can see just an elevated crust. This is called the posterior urethral crust. And at the junction of the bladder with the prostatic urethra, you will see slight elevation. This is known as the uvula of the bladder. This is exactly situated at the apex of the trigone of the bladder. And prostatic urethra has number of openings. These openings are all due to prostatic glands. Prostate is situated below the bladder neck, surrounding the first 3 to 3.5 centimeters of the urethra. It is 3 centimeters long, 3.5 centimeters wide. It is traversed by ejaculatory ducts. it has glandular tissue in fibromuscular stroma. So it has a fibromuscular stroma, that means it has glands, fibrous stroma, and smooth muscle. It has 5 lobes, 3 mucosal zones, and 2 capsules. What are these 5 lobes? A normal prostate, when you look at it, it is a compact structure and is divided by imaginary planes into 5 lobes. So if you take the normal prostate and then do a cut section or a coronal section and see, you will see only a compact structure. But by imaginary planes, it can be divided into 5 lobes: the anterior, posterior, middle, and 2 lateral lobes. You can see in this image, the anterior lobe is the one which is situated in front of the prostatic urethra. So the tissue of prostate situated anterior to the urethra is called the anterior lobe. Then posterior to the urethra, you can see the prostate gland can be divided into two planes by ejaculatory ducts. That part of the prostate gland situated above the ejaculatory duct is called the middle lobe, and that part of the gland situated behind the ejaculatory duct and behind the prostatic urethra is called the posterior lobe. So now we have seen 3 lobes: anterior, middle, and posterior lobes. And you focus your attention to the image on the left side, this one. That part of the prostate gland situated lateral to the prostatic urethra is called the lateral lobes. The anterior lobe, it lies in front of the urethra and contains fibrous tissue with little or no glandular tissue. So the anterior lobe has a lot of fibrous tissue and little of glandular tissue or no glandular tissue. This is also called as the anterior commissure. Because it has no glandular tissue, the adenoma of the prostate, that means the benign prostatic hypertrophy, doesn't affect this anterior lobe. So this point also you have to remember. This is also frequently asked in the PG entrance examination. The anterior lobe is not affected by benign prostatic hypertrophy. The lateral lobes, they are situated on either side of the urethra and contain fibroadenomyomatous tissue. And this is the commonest site of BPH. So this is the section of the normal prostate. You can see this is the coronal section and this is the transverse section. So in these 2 sections, you can see there is uniform structure of the prostatic gland tissue. But when benign prostatic hypertrophy develops, so this is the region which gets involved in benign prostatic hypertrophy. So this becomes hypertrophic. Then you can see 2 lobes, 2 definite lobular structures on either side of the urethra. The middle lobe. Already I told you, middle lobe is the one which is situated above the ejaculatory ducts. So it is situated between the ejaculatory ducts and the prostatic urethra. It is just below the bladder neck and contains plenty of submucosal glands which hypertrophies in BPH. When hypertrophied due to its position, it causes bladder outflow obstruction. So you can see here, this is the normal prostate gland. When prostatic hypertrophy develops, it appears like this. So there are 2 lateral lobes due to hypertrophy. And you can see the urethral crust in the prostate gland, it also got hypertrophy. And this uvula of the bladder has become hypertrophied. And you can see a mass-like projection into the bladder. So, because it is at the bladder neck region, the middle lobe can cause urinary tract obstruction. So this middle lobe passes, when it enlarges, it passes into the bladder because there is a plane of least resistance. So it passes between the mucosa, urethral mucosa, and sphincter. So it insinuates itself between the sphincter and the mucosa. So when it hypertrophies, it grows into the bladder in the submucosal plane between the mucosa and the internal sphincter, as there is least resistance in this plane. Hence, the internal sphincter cannot completely occlude the internal meatus during filling phase of the bladder. So the internal sphincter cannot completely close because something is projecting into it. So it cannot do its total closure of the bladder neck. This results in leakage of few drops of urine into the sensitive prostatic urethra when bladder is getting filled. So when bladder is, we have seen capacity is about some 350 ml. Even when there is some 100 ml, 150 ml, this urine will now leak into the prostatic urethra because the internal sphincter is not tightly closed. So this will cause sensation of urination for the patient. So for every 100 or 150 ml of urine in the bladder, the patient has to run to the bathroom. So there will be more frequent emptying of the bladder. So that is called the frequency of urination. So this causes urgency and frequency. Then the posterior lobe is situated behind the urethra and the median lobe. So this is the median lobe. This is the prostatic urethra. So behind these two structures and behind the ejaculatory duct is the posterior lobe. It contains prostatic glands and it is site for prostatic cancer. So now we have seen the various lobes of the prostate gland. Now can you tell me what are the lobes where benign prostatic hypertrophy occurs? In which lobes BPH develops? What about others? Which lobes develop BPH? Just to know whether you are following or not, please answer. Okay. So that's right. It's the lateral and median lobes. Then which lobe of the prostate is prone to develop carcinoma of the prostate? Which lobe develops carcinoma of the prostate? Yes, very good. Here the posterior lobe. So the lobes are 5. We have seen 2 lateral lobes, 1 median lobe, 1 posterior lobe, 1 anterior lobe. Now the glandular zones. There are mainly 3 zones. Central zone containing urethral glands. So this is the yellow colored one, is the central one. This is the urethra, and around the urethra there are urethral glands. Then second zone is the transitional zone or periurethral zone containing submucosal glands and it is the place where BPH develops. The third one is the peripheral zone containing glands proper, which is the area of carcinoma. So there are three zones. One, urethral zone. Second is the periurethral zone. Third one is the peripheral zone. The prostatic urethra, it has the openings of the prostatic glands, ejaculatory ducts. Hence, an infection occurring in the prostate is difficult to eradicate as any one of these duct orifices acts as a safe home for the microbes. There is vermontanum and prostatic utricle lie on the posterior wall. So this elevated structure is called the vermontanum. Just below this structure is the apex of the prostate. And below the apex of the prostate is the membranous urethra. The membranous urethra is surrounded by external urethral sphincter. So when you are doing prostatectomy operation by endoscopy procedure, that is called transurethral resection of prostate, abbreviated as TURP. So when you are doing TURP, you must cut the enlarged lobes above the vermontanum. You should not go below the vermontanum, because if you cut below the vermontanum, there is a chance of damaging the external urethral sphincter. So the sphincter's muscle will never go above this line, above the vermontanum line. So you must keep your cutting loop above the vermontanum only. This is the vermontanum. So on the vermontanum, you can see a small opening. This opening is prostatic utricle. This is the prostatic utricle. So over the vermontanum, there is prostatic utricle. Prostatic utricle is a vestige. There is no significance for that. Vermontanum means it is only an elevation, that's all. To eject the prostate during ejaculation. So retrograde passage of semen into the bladder along with internal sphincter. Yes, I am working on that. Dear students, I hope you are able to see the video as well as you are able to hear the audio. Is everything okay? Okay, that's fine. Smooth muscle in the prostate. Prostate contains smooth muscle to eject the prostate secretions during ejaculation and controls retrograde passage of semen into the bladder along with the internal sphincter. This smooth muscle also gets hypertrophic and becomes more sensitive in BPH. The alpha energy blockers like prazosin, terazosin relieves the spasm of these muscle bundles in relieving the obstructive symptoms due to BPH. Capsules of the prostate. There are two capsules. Outer facial capsule, which is condensation of the visceral layer of the pelvic fascia. The second one is the true capsule of the prostate. And between these two capsules lie the prostatic venous plexus. Physiology. Prostate secretion prolongs the lifespan of the sperms. Prostate gland assists in liquefaction of semen due to its serine protease, that is the prostate specific antigen. Prostate is under the influence of testosterone hormone. Testosterone is converted by 5-alpha reductase enzyme into 5-dihydrotestosterone. And this is the active form of testosterone. Drugs which block this enzyme makes prostate selectively devoid of testosterone activity. So in BPH, certain drugs are used to limit the growth of the prostate gland, because prostatic gland growth is dependent upon 5-dihydrotestosterone. This production is being blocked by 5-alpha reductase enzyme blockers. Prostatic urethra has sensory receptors which control bladder emptying. So we have seen yesterday the micturition reflex. There are receptors in the bladder wall. They are the stretch receptors. Whenever bladder is distended to a certain level, then the stretch receptors are stimulated. They send stimuli to the brain. Now, if the person wants to avoid urine, the facilitatory responses will come from the brain and will cause stimulation of the sacral centers or the micturition centers, whereby the bladder is contracted and internal urethral sphincter is relaxed. Urine passes from the bladder into the prostatic urethra and goes out. Once the urine is completely emptied, then the stretch reflexes, they don't function. That is why there is no stimulus to the bladder from the micturition center, so the bladder stops contracting. And this is aided by the sensory input from the prostatic urethra also. As long as urine is flowing in the prostatic urethra, the receptors that are there in the prostatic urethra will send the impulses to the brain that the urine is still flowing. So as long as the urine is flowing, the bladder gets contracted. Once the prostatic urethra is completely emptied of urine, then bladder contraction will be absent. That means prostatic urethra also is sensitive receptor. So if the prostatic urethra is being pulled into the bladder, how? By the median lobe enlargement. When the median enlarges, it grows upwards. Along with it, the prostatic urethra also goes into the bladder. So the prostatic urethra also is exposed to the bladder lumen. So when urine touches this sensitive urethra, then patient feels as if urine is coming. So the bladder contracts. So micturition starts. So the patient gets an urgent feeling to micturate because of this prostatic urethra being introverted into the bladder. So this everted mucosa into the bladder of a BPH patient plays an important role in symptoms of prostatic hypertrophy. So prostate is a conical organ situated below the bladder neck. It is traversed by ejaculatory ducts. You can see in the coronal section, two lateral lobes, prostatic utricle. Two openings are there. These are the openings of the ejaculatory ducts. In the central, there is a small opening, that is the prostatic utricle. And the apex of the prostate surrounded by the membranous, external urethral sphincter here. When benign prostatic hypertrophy develops, you can see well-defined lateral lobes on either side and a central median lobe. The median lobe projects inside, and because of its projection, there develops a post-prostatic pouch. So you can see a post-prostatic pouch here. So with this anatomy, now we'll go to the topic of benign prostatic hypertrophy, also called as benign prostatic hyperplasia, also called as benign enlargement of the prostate. So these three names belong to the same structure. Prostatic utricle is a vestigial remnant of the Mullerian ducts. You see, Mullerian ducts develops in the females into female genital tract, into the uterus, fallopian tubes, and upper part of the vagina. That atrophies in the male counterpart. So the terminal part of the Mullerian duct persists in the prostatic as prostatic utricle. Because it is developed from the Mullerian remnant, that means a part which develops into the uterus. In the males, this is called like the utriculus or utricle. Utricle means small uterus. So it is actually not uterus, it is analog of the uterus in males. So this is benign prostatic hypertrophy pathology. It is a fibromuscular adenomatous hyperplasia of the prostate gland. So there is hyperplasia of the fibrous element, muscular element, that is smooth muscle element, and the glandular structure. All the three are hyperplasia. It is not a neoplasm, it is a hyperplasia. That is what's called the fibroadenomyosis. It is not called as fibroadenomyoma. It is not myoma. It is only meiosis. So whenever hyperplasia is there, we call it adenosis, meiosis, like that. It is a normal physiological condition. The prostate enlargement is a natural process of life, like graying of hair, arcus senilis, and atherosclerosis. So as age advances, prostate gland also starts enlarging in size. Why? This is all because of the hormonal imbalance. About 50% of the persons past 50 years develop microscopic evidence of enlargement of the prostate. But only few develop clinical and pathological effects of the disease. So though there is enlargement of the prostate, the patient may not come to you with urinary tract symptoms. The urinary tract symptoms will be there only when the enlarged lobes encroach onto the prostatic urethra. If they grow outside without encroaching on the prostatic urethra, then there are no symptoms. If they encroach onto the prostatic urethra, cause a distortion of the urethra or urethral architecture, then there will be the symptomatology. That's why all elderly persons or all old persons need not suffer from symptoms of prostatic hypertrophy. Though they have prostatic hypertrophy, they do not exhibit the symptoms. Why this hypertrophy occurs in elderly people? Hormonal theory. The imbalance in decreasing testosterone and normal estrogen in aging persons results in the changes in the submucosal glands of the prostate, like the changes that occur in the breast in fibrocystic hyperplasia. There is one more theory called neoplastic theory. Probably it is a benign neoplasm. Of course, it is not being accepted by many pathologists. So, what happens in BPH? There is benign hypertrophy of the glandular, muscular, and fibrous tissue. So, the urethral glands and periurethral glands are the transition zone. They are mainly affected. So, that leads to the enlargement of two lateral lobes and one median lobe. Central and submucosal glands are involved in the hypertrophy, leads to formation of two lobes on either side of the prostatic urethra and enlargement of the median lobe. These lobes grow into the bladder, causing an intravesical collar around the internal urethral meatus. The normal prostatic tissue around the hypertrophic lobes get compressed, making the posterior lobe into a capsule. So these enlarging lobes, they cause compression of the surrounding prostatic parenchyma. So the surrounding prostatic parenchyma gets compressed and becomes something like a capsule. It gets thinned out. So that is called a false capsule. So enlarged prostate has three capsules: an inner false capsule of compressed posterior lobe, then middle one is the true capsule, and outer one is the pelvic fascia condensation. That's called the facial capsule. When the lobes are enlarged, prostatic urethra gets elongated and curved. So normally it is a straight path, but when the median lobe enlarges, it becomes angulated. And it becomes something like slit-like. So you can see it is a longitudinal slit. The hypertrophic middle lobe acts as a dam and results in collection of urine behind it in the post-prostatic pouch. So this is the normal prostate. You can see the interior of the bladder. It is just like a funnel. When there is median lobe hypertrophy, it projects itself into the bladder lumen, and there develops a posterior pouch. This is called post-prostatic pouch. And there is smooth muscle hypertrophy. It adds to the bladder neck obstruction along with the enlarged lobes. The smooth muscle becomes hypersensitive. Then because of BPH, there will be some changes in the bladder because there is bladder outlet obstruction. To overcome the obstruction, the detrusor muscle hypertrophies and projects into the lumen of the bladder, giving it a trabeculated appearance. This is called trabeculated appearance. The mucosa in between the hypertrophic muscle bundles produce saculations of the bladder mucosa. As yesterday we have discussed about this, there will be saculations in between these muscle bundles. These saculations later progress to bladder diverticulum. You can see this trabeculated appearance of the bladder. Stones form due to stasis or infection. If the obstruction is not relieved, the hypertrophic muscle becomes atonic. Then changes in the ureter, there will be reflux due to increased pressure in the bladder. That reflux leads to hydroureter and hydronephrosis. So raised intravesical pressure lead to vesicoureteral reflux, lead to hydroureter and hydronephrosis, and there can be ascending infection leading to chronic renal failure. So this is the pathology of benign prostatic hypertrophy. Then clinical features. The clinical features are due to irritative symptoms and obstructive symptoms. So there are two components in the clinical manifestations. Irritative symptoms. The median lobe of the prostate, it enlarges into the bladder between the internal urethral sphincter and the mucosa. As it grows upwards, it carries the prostatic mucosa also along with it into the bladder lumen. Because of this, there will be hypersensitive micturition reflex. So these are due to exaggerated responses from the bladder due to this intravesical protrusion of sensitive prostatic mucosa and due to smooth muscle and neurovesical incoordination. Smooth muscle becomes hypertrophic and hypersensitive. So all these things, they produce these irritative symptoms. So these symptoms are called as prostatism, but recently they are being called as the lower urinary tract symptoms, LUTS. LUTS means lower urinary tract symptoms. They are the frequency. It is the earliest symptom of the prostatic hypertrophy. At first it is nocturnal and later progresses to both day and night. It is due to intravesical protrusion of sensitive prostatic mucosa. The second manifestation is urgency due to inefficient closure of the internal sphincter and passage of urine into the sensitive prostatic urethra, causing a feeling of urgent voiding. Both these factors, inefficient closure of the internal urethral sphincter because the prostatic medial lobe is projecting into it, and sensitive prostatic urethra is exposed to the bladder, so there is a feeling of urgent voiding. Then urgent continence. If the person postpones micturition, there may be incontinence of the urine. Enuresis. The hypersensitive prostatic mucosal stimulation evokes bladder stimulation before cortical awareness while sleeping, resulting in bedwetting. So the BPH patients also have this feature of bedwetting. So like that, what they have experienced in their infancy and childhood, they will again have it in their old days. That's why old age is also called as second childhood. Then the obstructive symptoms. So frequency, urgency, and enuresis. These are the irritative symptoms. Then because there is projection of the lobes into the urethra gets narrowed, deformed. It becomes something like a slit, a longitudinal slit. So it causes bladder outflow obstruction. So what are the features here? Number one, hesitancy. The patient has to wait. That means the patient gets the urgent feel of voiding. So he actually runs to the bathroom. And once he goes to the toilet, if he wants to pass urine, the urine won't come. he has to patiently wait. He has to relax his sphincters. Then only the urine starts coming. So there will be hesitation of the bladder to void. It is mainly due to the occlusion of the internal urethral sphincter by the enlarged lateral and medial lobes. So the internal sphincter, into the internal urethral sphincter, the medial and lateral lobes are projected. That is why though the internal sphincter relaxes, there is not much opening. So there is hesitancy. It has to relax still more. So the patient has to patiently wait till it gets completely relaxed and initiation of the micturition starts. If the patient strains to empty his bladder, the straining will cause more pressure on these lateral lobes. They get more closure and the stream becomes still more narrow. The stream will be intermittent and variable. Weak stream, which tends to stop and start with the loss of projectile power. Post-micturition dribbling of urine. Then feeling of incomplete evacuation of the bladder because of the residual urine. All the urine is not being emptied. Part of the urine gets retained. There may be overflow incontinence if there is chronic retention. So due to chronic retention, atonic bladder distends and urine dribbles out. Sometimes there will be precipitation with acute retention. So prolonged postponement of micturition. So this prolonged postponement can occur in the early postoperative period or when patient is confined to bed for some intercurrent illness. This leads to congestion of the bladder and prostate, and that will aggravate the blocking already present. So if it is partial narrowing, becomes a complete narrowing due to edema and congestion of the prostatic urethra whenever the micturition is forcibly postponed. For example, a BPH patient who is having frequency, urgency, intermittent stream, and difficulty in micturition has to travel in a bus for a very long distance. So because he has in the house, he used to visit the bathroom for every 1 hour. He can't do that in the bus. So he will patiently wait and then he postpones forcibly the micturition. So how to postpone micturition? By forcibly contracting the external urethral sphincter. So when the external urethral sphincter is contracted forcibly, then urine cannot come. So the bladder, though it wants to push the contents out, because the external urethral sphincter is contracted, its contractions won't help. So that will lead to temporary postponement of micturition. So this causes congestion of the bladder, neck, and prostatic urethra. So because of the congestion, there develops edema. So with the edema, the partially occluded prostatic urethra becomes totally occluded. So this makes the patient to go into acute retention. That is why if you do surgery for a BPH patient, not prostate surgery, some other surgery like hernia surgery, you must be careful. You must ask the patient to void urine 2 to 3 hours after surgery because you are giving a lot of saline. So bladder gets distended. Patient is under sedation. So his blood is not getting emptied. So whenever bladder distends, that produces venous blockage and venous congestion at the bladder neck, producing edema. So you must always advise the patient to void as early as possible after surgery if the patient is having a benign prostatic hypertrophy. Other features, there may be hematuria. It is due to congested veins at the base of the bladder in prostatic hypertrophy, chronic renal failure, If the patient develops bilateral hydronephrosis and hydroureters, he may go into chronic renal failure. So then the patient will have headache, drowsiness, vomiting, or impaired intellect. Abdominal examination in prostatic hypertrophy may reveal normal, no abnormalities detected. There may be distended bladder with overflow incontinence due to chronic retention. So patients may have chronic retention causing this painless distension of the bladder. Renal angles may be full, dull, or tender due to infection or hydronephrosis. Epidermolysis may be present due to retrograde spread of infection from the prostate via vas deferens. Distal rectal examination, this is very, very essential. The size, shape, consistency of the prostate and mobility of the rectal mucosa over the prostate gland is examined. So this is an ideal position to examine for the prostatic hypertrophy. So in this knee elbow position, you can pass your finger freely and you can evaluate the prostate gland. So normally what happens is whenever the lateral lobes enlarge, so normally the posterior surface of the prostate gland is smooth. If the lateral lobes enlarge, they bulge. So because of the bulge, there develops a median groove. A median groove will be present when you do distal rectal examination. So for a normal prostate, you don't feel a median groove. For a benign prostatic hypertrophy, you will feel a median groove in between the two lateral lobes. And we have seen that in the anatomy, posterior lobe is prone to develop carcinoma of the prostate. So the enlargement of the prostate gland is because of carcinoma. Then the whole posterior lobe gets enlarged. So then there is no median groove. So in any enlargement of the prostate, you must always look for the median groove presence. When the median groove is present means it indicates that it is a benign prostatic hypertrophy. If median groove is absent means it is due to carcinoma of the prostate. In BPH, it manifests as firm, elastic, non-tender, uniform enlargement of the prostate with a groove in the midline. In carcinoma, the posterior midline groove is absent because the growth arises from the posterior lobe. Differential diagnosis of prostatic hypertrophy, because the patient is having difficulty in micturition, we have to differentiate it from stricture of the urethra, where it occurs in the young individuals and straining improves the micturition here, but straining causes retardation of urination in prostatic hypertrophy. Carcinoma of the prostate, hard nodular prostate with obliteration of the medial groove. Then biochemical investigations like serum acid phosphorase and PSA will help to differentiate both. Then neurogenic bladder. We have seen yesterday there are three types of neurogenic bladder. One is the spinal shock phase, where there is atony of the bladder. Then after recovering, that means after 2 to 3 weeks to few months, there will be automatic bladder in case of upper motor neuron lesions. In case of lower motor neuron lesion means lesion affecting the spinal centers or the nerves, peripheral nerves supplying the bladder. We have seen hypogastric plexus. So the hypogastric plexus is damaged, or if the spinal centers are damaged at S2, 3, 4, then patient will get the neurogenic bladder. So example, disseminated sclerosis, Alzheimer's disease, Parkinson's disease, pelvic nerve damage due to surgery or neoplastic infiltration, patients may develop this neurogenic bladder. So in neurogenic bladder also we have seen atony and then automatic bladder. So where there can be frequency and difficulty in micturition, so you have to differentiate BPH. If it is transection of the cord, then there will be paraplegia. But in these conditions, there will not be any paraplegia. If it is a lower motor neuron lesion, then patient will not have any paraplegia. You will have only the pelvic neuropathy. So neurological examination, especially for the saddle anesthesia and ankle jerk, helps to differentiate these conditions. So if you look at the dermatome pattern of S234, S234 gives nervi urgentis. Nervi urgentis means it is parasympathetic sacral outflow. It is S234. Similarly, pudendal nerve also gives or comes from S234. The sensory innervation of the S234 is here. The perianal. So this is the anal orifice. You can see the S2 is in the midline of the thigh posteriorly. The S3 is around the anus, and S4 is very close to the anus. So this is the sensory innervation. So if S2, 3, 4 spinal segments have been damaged, then there will be anesthesia in this region. So S2, 3, 4 become anesthetized. So this part, the person sits on a saddle of a horse back, will be in contact with the saddle. That is why this particular area of anesthesia is called as saddle anesthesia. This is a repeatedly asked question in your theory examination, your medicine. Saddle anesthesia. Saddle anesthesia means that part of the perineum which comes in contact with the saddle when you are sitting on a horseback, and that part gets anesthetized. That is nothing but the segment dermatomes of the S2, S3, and S4. The same S2, 3, 4, they give nervi urgentis. That means parasympathetic supply to the bladder. So when there is evidence of injury to the S2, 3, 4 centers, you can conclude that there will be damage to the bladder function also. So the patient may have neurogenic bladder. Then there is one more condition called the idiopathic detrusor instability. That means detrusor muscle function becomes decreased. So there is bladder smooth muscle degeneration. This occurs in the old age. So because of the degeneration, the bladder contractile ability comes down. So the bladder contractile ability comes down, what will happen? The force of urination comes down. So the stream becomes narrow and intermittent. So it is just something like the BPH symptoms. So because old age is there, because there is narrowed stream, so you always feel that it is due to BPH. But it may not be due to BPH, it may be due to detrusor instability. You must identify this condition before you plan to do surgery for BPH. Otherwise, even after doing surgery, the patients will have the same trouble of difficulty in micturition and narrow stream. Then other differential diagnosis is bladder neck hypertrophy, where there is smooth muscle hypertrophy at the bladder neck causing obstruction. Then fibrosis at the bladder neck causing bladder neck stenosis. Investigations to identify the degree of urinary flow impairment. So the patient's main complaint is difficulty in passing urine. So we have seen the difficulty in passing urine can be due to So the investigations. So whenever an elderly person comes to you with symptoms of difficulty in micturition, like narrow stream, intermittent stream, frequency, urgency, then you have to investigate him. So the aim of the investigation is number one, to identify the degree of urinary flow impairment. To assess the volume of the prostate. To differentiate the enlarged prostate from carcinoma. So the investigations are routine urological investigations, that is urinary analysis and culture of the urine, because the frequency and urgency can be there for cystitis also. So you have to examine the urine for microscopic examination as well as for culture test. Plain X-ray abdomen for evidence of any caliculi, secondary deposits in the pelvis or spine. So pelvic deposits, secondary deposits will be there in the pelvis or spine in case of carcinoma of the prostate. Ultrasound scan and IVP to demonstrate hydroureters, hydronephrosis, amount of residual urine in the bladder by pre and post micturition examination. Fill-in defect in the bladder due to intravesical enlargement of the prostate can be seen in intravenous pyelography. Then renal function test, creatinine and urea. So if a patient with difficulty in micturition, these are the investigations you have to do. You have to do urine analysis, plain X-ray abdomen for evidence of caliculi, intravenous pyelography for any obstructive uropathy, then prostatic shadow in the bladder, then for estimation of the residual urine. Renal function test to know about the function ability of the kidneys by doing creatinine and urea estimation. This is an example of IVP. You can see this is the IVP picture showing the cystogram phase. Cystogram phase means the bladder, when it is filled, it is called cystogram phase. You can see a semilunar shadow here. Normally, the bladder will fill up to the bottom of the pelvis. So you will see normally up to here. But this part is not filled. Why? There is some space occupation here. What is space occupying lesion here? That is a smooth enlargement. So a smooth enlargement, it means it is most likely due to prostatic median lobe. When the median lobe projects like this, the bladder is not filled in the lower part. Then investigations to identify the urinary flow impairment is called uroflowmetry. So patient says that he is having difficulty in micturition and stream has become narrow. How much narrow it has become? When you ask the patient, it is very severe narrowing. But you have to evaluate. So there is a method that's called uroflowmetry. What you do, the speed of urination is evaluated. So you ask the patient to void urine. While the patient is voiding urine, there will be a machine to calculate the speed of urination. That is called uroflowmetry. So with that, what you can normally, it will be more than 15 ml of urination per second will be there. 15 ml in a second. You can estimate the patient's urination ability with how much speed he is passing. If it is less than 10 or 12 ml per second, then it's considered as a considerable disability of the patient and he needs surgical intervention. So normally it's 15 ml per second. A flow rate of less than 10 ml per second is suggestive of bladder outflow obstruction. The bladder outflow obstruction can be due to BPH commonly, detrusor instability, neurogenic bladder, bladder neck hypertrophy, carcinoma prostate, bladder neck stenosis, stricture of the urethra. So all these conditions, they cause the bladder outflow obstruction. So by doing uroflowmetry, you can evaluate whether there is any obstruction or not. That's all. It won't tell you whether it is BPH or carcinoma or stricture of the urethra. It simply says there is outflow obstruction. So this is the normal uroflowmetry. So initially the pressure is or speed is slow. So immediately it attains a peak, then it terminates. In BPH, it will be like this. There will be intermittent ups and downs. In urethral stricture, it is a static low amplitude wave. Then to assess the size of the prostate, you can do ultrasound scan. With this ultrasound scan, you can evaluate the amount of residual urine as well as size of the prostate. You can assess the kidneys, bladder, and prostate. Transrectal ultrasonography to get high resolution image of the prostate gland. It is to measure the size and direction of prostatic enlargement, to evaluate the texture of the prostate. The cystourethropy is useful to diagnose other associated conditions like stricture urethra, intravesical neoplasm, or calculus. So when you do cystoscopy, this is the normal prostatic urethra. So these are the lateral lobes, which are not enlarged. If prostatic hypertrophy is present, you can see the lobes, they encroach onto the urethra. A circular urethral opening has become a slit-like opening. And there is projection into the posterior side. This is the median lobe hypertrophy. And if you pass a flexible cystoscopy and bend it and look at the neck of the bladder, so you are looking from the top. So by passing a flexible cystoscope, you have bent the cystoscope and you are looking at the bladder neck region. You can see here the projected lateral lobes here. Then investigations to differentiate BPH and carcinoma. Biochemical investigations. There is elevated acid phosphatase. Normal is 1 to 4 King Armstrong units. It will be elevated. And more useful test is the PSA, prostate specific antigen test. This is elevated in carcinoma of the prostate. This normal is 4 nanomoles per liter. It is elevated in carcinoma of the prostate. Then biopsy of the prostate gland with the help of a Wim-Selmans needle or true-cut needle through the perineum or rectum. You can take a biopsy. So the investigations for benign prostatic hypertrophy being, first you do routine urine examination. Then you can take an X-ray of the chest, ultrasound scan. The ultrasound scan will tell you about the prostate size, texture of the prostate, residual urine in the bladder, associated hydroureters and hydronephrosis. So you have estimated the size of the prostate. Normal size is 3 centimeters by 3.5 centimeters. If it is enlarged, then you do uroflowmetry to evaluate for the how much speed, with what speed the patient is able to void the urine. So if the stream has reduced, then you will definitely make a diagnosis of bladder outflow obstruction. If it is less than 10 ml per second, this bladder outflow obstruction. Then what you do, either due to stricture urethra or due to BPH or due to dyssynergy of the bladder, what you do a cystoscopy. So cystourethropy will reveal any strictures and enlarge the prostate gland and interior of the bladder. So these are the investigations you do, and in some cases you can do intravenous pyelography also. Then you do enzyme estimations, that is the PSA test to differentiate carcinoma from the BPH. Normally is 4 units, 4 nanograms. The treatment of BPH, conservative treatment. So the patient comes to you with difficulty in micturition, then first what you do is advise him to avoid postponement of micturition because it can cause acute retention of urine. Associated urinary infection is treated by appropriate antibiotics. Then drugs. Alpha blockers, which block smooth muscle of the prostate, like prazosin, terazosin, they help to relieve the irritative and obstructive symptoms. Drugs which block 5-alpha reductase. We have seen 5-alpha reductase is the enzyme which converts testosterone into dihydrotestosterone. Dihydrotestosterone is the active form of the testosterone which causes stimulation of the prostatic parenchyma. So you block the 5-alpha reductase enzyme. So this reduces the intraprostatic conversion of testosterone to its active form and causes shrinkage of the prostate by stromal involution. Because the stromal development is dependent upon the testosterone. So once you block the testosterone or 5-hydrotestosterone, then the stromal involution takes place, causing reduction in the size of the prostate gland. These drugs improve the flow rates and long-term results are awaited. Surgery indications, prostatism and features of obstruction not controlled by medical measures. So you give medical measures, but the patient is feeling a lot of difficulty. He has to wake up a number of times in the night. The stream is very narrow. He has to wait in the bathroom to pass urine for minimum 15 minutes. And again, every hour he has to go to the bathroom. So this is a social embarrassment as well as personal inconvenience for the patient with lack of sleep. So you give medicines, that is alpha blockers and 5-alpha reductase enzyme. So if they are not helpful, not giving much relief, then you plan for surgery. So indication is prostatism with features of obstruction not controlled by medical measures. Then recurrence of retention of urine after catheterization. If a person comes to you with acute retention due to BPH, how do you manage? You pass a catheter. If ordinary catheter cannot be passed, then what type of catheter you choose to relieve the retention? Yesterday we have studied. Oh, very good. You have given a very prompt answer, Santi. It is the Cody catheter. That means catheter which is bent at the tip. So that catheter is chosen for relieving the retention in a patient with BPH. If the patient comes to the chronic retention of urine, that means whenever residual urine is more than 200 ml, you call it as chronic retention. Or peak flow rate is less than 12 ml per second. Presence of hydroureters, hydronephrosis, or uremia. The presence of complications like stone, infection, diverticulum, hematuria, or uremia. So these are all the indications for surgery in a patient with BPH. The surgical approaches. This is the prostate gland. So there are many approaches to do surgery for the prostate gland. The first one is called suprapubic because your approach is above the pubis. Suprapubic transvesical prostatectomy. This is called suprapubic transvesical prostatectomy. That is one approach. The second approach is again suprapubic, but it's not through the bladder. It is behind the pubic bone. So this is the retropubic approach. So you go behind the pubic bone, separate the prostate from the underlying fascia, incise the outer capsule, then enucleate the hypertrophic lobes. So this is called the retropubic approach. The third one is through the perineum. And the fourth one is through the urethra. That is called transurethral prostatectomy. The hypertrophic prostate lobes are enucleated from within the false capsule of the compressive prostatic tissue. The approaches are suprapubic transvesical prostatectomy, called as the Freyer's operation. The prostate is approached to the bladder from a suprapubic incision. So you make an incision in the skin, linea alba, then the bladder anterior wall. Then what you do is you pass your finger into the bladder. Then pass your finger through the neck of the bladder. And with force, you break the anterior commissure, that is anterior lobe. Then you will be able to sweep your finger around the enlarged prostatic lobes. So the prostatic lobes are dissected by blunt dissection, and they are extracted out through the suprapubic incision. So you can see these enlarged lobes will be felt through the bladder wall, bladder lumen. So you make an incision around this in the mucosa. Once you make an incision around the mucosa, you can pass your fingers by the side of these enlarged lobes, sweep all around and remove the prostate lobes. The second type of procedure is called retropubic prostatectomy. A suprapubic incision is made, prostate is approached through the retropubic space. Its true and false capsules are incised. Hypertrophic nodule of the prostate is excised. Then perineal prostatectomy, the prostate is approached through the perineum in the space between the rectum and the urethra. Then fourth one, the transurethral resection of the prostate gland. A resectoscope is passed via the urethra, and strips of prostate tissue are excised from the bladder neck to the verumontanum. Just I will show you a small video clip about the transurethral resection of the prostate. Yes, by blunt dissection, they can resect it out.
Symptoms of an enlarged prostate include Tissue removed during a resection of the prostate or TURP is routinely screened for the presence of cancer. On the day of your operation, you will be asked to put on a surgical gown. You may receive a sedative by mouth, and an intravenous line may be, and the nurse, a well-lubricated instrument called a resectoscope, is then gently inserted into the urethra. When the resectoscope reaches the back of the penis, your doctor will pull the penis downward in order to create a straight path into the prostate. Once the instrument is inside the prostate, your doctor will extend a small loop of sharp-edged wire from the end of the resectoscope. Using this tool, your doctor will then scrape excess tissue from the prostate, restoring it to its normal size. Tissue removed from the prostate may be sent to a laboratory for analysis. When the surgery is complete, your doctor will remove the resectoscope. Your doctor will probably ask you to wear a temporary Foley catheter. A Foley catheter is a narrow tube inserted through your urethra and into your bladder. The catheter is connected to a bag that is attached to your leg by a strap. While the Foley catheter is in place, urine will pass from your bladder into the bag. You will not need to urinate into a toilet. The nurse will show you how to change the bag when it's full. An appointment will be made for you to return to the doctor's office in a couple of days to have the catheter removed.
For transurethral resection of prostate, that it is an endoscopic, mini-invasive technique for the treatment of prostatic hyperplasia. This video shows how this technique is performed. Let's see some anatomic landmarks that helps us understand where we are and what we have to do. You can now see the prostatic urethra. Here, the lateral and large prostatic lobes obstruct the urethra. Uverum montarum is the point where the sphincter begins and where the prostate ends. As we proceed with the endoscopic instrument towards the bladder, we notice better the obstruction that the enlarged prostate determines. Just before entering the bladder, we notice a third prostatic lobe known as median lobe that also causes obstruction of what we call the bladder neck. The bladder neck is where the bladder and the prostate meets. Finally, the bladder is entered. The operation begins, and it is performed with a special instrument called resectoscope. High-frequency electric energy is used during this resection. The electric energy passes through a special loop, as you can see, that cuts off the prostatic tissue piece by piece. The same loop coagulates the vessels, controlling the bleeding. With this technique, progressively the prostatic tissue that exceeds and obstructs the urethra is resected. The final result is a creation of a wide urethra, like a wide canal. The bladder now can easily empty the urine. The resected prostatic tissue is removed through the resectoscope and histological examination is performed.
Okay, this is the video clip on the transurethral resection of the prostate. Now, this is one of the commonest procedures done for prostatectomy operation. So the open procedure, that is by enucleation with the fingers, is not being practiced now. For the past 20 years, I have not done a single case of prostatectomy because all the prostatectomies are being done by urologists with transurethral resection of the prostate. So I have also discontinued doing prostatectomy by open method for the past 20 or 25 years. Yes, the up to the vermontanum it will be resected. Below the vermontanum it is not resected. Of course, in the first video it is shown that vermontanum also is being resected. That is of course a video for the layman. That is why they have not shown the details. The second video they are showing the resection up to the utricle or the vermontanum. Vermontanum is not resected. When you remove these prostate lobes, the prostatic urethra also comes out. Because it is a transition cell mucosa, it regenerates. So from the bladder, it regenerates down into the prostatic urethra. So the prostatic urethra gets lined by mucosa after 3 to 4 weeks time. So there will be big cavity will be there. So the cavity gets lined by this mucosa by regeneration from the bladder as well as from the urethra. Continuity is maintained. That is why you keep the catheter in situ for minimum of 2 to 3 weeks. So around the catheter, there will be fibrosis, and over the fibrosis, there will be re-epithelialization due to regeneration. So continuity is maintained. But because there is a lot of fibrosis, there is a chance of stricture at the bladder neck. So one of the complications of prostatic surgery is stricture development. Complication of the procedure, hemorrhage. Incontinence. So if you cut the sphincters, then there is a chance of developing incontinence. Then infection of the prostatic bed, stricture of the prostatic bed, there is bladder neck. Then retrograde ejaculation. The smooth muscle of the prostate is being removed. That's why whenever the patient is ejaculating during intercourse, then there will be passage of semen into the bladder. Normally, the internal sphincter will be closed. The smooth muscles will contract, not permitting the semen to go into the bladder. But because the smooth muscle is being removed, so the patients will have the ejaculation into the bladder. So they don't get the complete orgasm. Complications of the procedures being hemorrhage, incontinence. Then the other complication is the extraperitoneal perforation of the bladder. Sometimes there may be accidental injury to the bladder while resection is being done, so that may cause the tear of the bladder. The newer models of treatment, microwave and laser coagulation of the prostate with the help of machines kept in the urethra or rectum delivering energy. So with this microwave energy, the prostate is being enlarged, the prostatic lobes become necrose. Then placement of the intraurethral stents. So this is the prostatic hypertrophy. We will close this session and tomorrow we will continue. So here are some doubts. Prostatic urethra enters BPH. Does it descend down after surgery? Yes. The prostatic urethra also will be removed during surgery. There will be regeneration of the prostatic epithelium. So this regeneration, because it's a transitional epithelium, it has the capacity to regenerate. So it regenerates and lines the prostatic urethra, prostatic bed afterwards. Yes, Sandy, you can speak. I will. Okay. Now you can speak, Sandy.
Sir, actually, yesterday you told. Hello, sir. Can you listen me, sir?
Sandy, you wanted to speak. Please speak out.
Sir, can you listen me now? Hello. Hello. Hello, sir.
Okay. Any doubts? You're not able to speak? Why?
Hello, sir.
No, it is unmuted. You can just check. You try to speak. Now you try.
Hello, sir. అవ్వట్లేదు. Sir, can you hear me now?
I have muted my mic. Now you can speak, Sandy.
Sir, can you hear me now?
Yes, I can hear you. Tell me.
Yes, sir. Actually, yesterday you told the 3 levels of the spinal shock and all.
No. There are not 3 levels.
3 stages. Sorry.
I says 3 types of
Sir,
neurogenic bladder.
Yesterday, that means in Bailey and Love, a statement is given, sir, that when there is an lesion below the pons, when the higher centers are affected, then there will be bladder sphincter dysgenesis, dyssynergy.
Okay.
But you mentioned yesterday that because of the sphincter, human palsy, there will be hypertonicity of the sphincter, external sphincter, right? That means the distal sphincter. Yes, sir.
Yes,
So
that's right.
this external sphincter receives the innervation from the pudendalum, that is a somatic nerve, sir, and
Yes, you are
it
right.
in turn receives the innervation from the pons.
That's true. Yes, right. You're right.
When there is no connection, in human palsy, when there's a lesion in the below the pons, then the innervation from the brain will not come to the somatic nerve, sir. Then there will be no sphincter hypertrophy. Contraction.
Okay. I can understand your question.
Then
Thing
how
is,
will yes, sir.
in hemiplegia due to cerebral thrombosis, you have seen any case hemiplegia or paraplegia?
Yes, sir.
Yes. What will happen to the muscles? Are they spastic or flaccid?
So they're spastic.
They are spastic. Why? The upper centers are knocked out. Then why they are spastic?
because of this lower, the spinal segments are normal, sir.
Yes, spinal segments are normal and the control from the cortical centers has been knocked down. Then in that case, what will happen is the spinal centers, there will be hyperreflexia will be there. When the upper motor function is not there, the spinal centers, they behave in hyperreflex mechanism. So because of that, the muscles will undergo spasticity. So in the same way, though the pons levels below pons is there, so pons level below pons is affected. What is happening? Though this impulse is not coming from the pons, but the micturition center is there situated in sacrum, sacral cord. So those becomes hyperreflexia. So because of that function, the external sphincter undergoes spasm. Just like a paraplegic patient going into clasp knife rigidity, the bladder external sphincter also undergoes the clasp knife rigidity like function. That means it undergoes spasm. So there will be automatic bladder where bladder is contracting, but sphincter is not relaxing. So this produces bladder sphincter dyssynergia.
But it has nothing to do with there is a sacral, in the sacral segment there is a micturition center also, but it
Yes,
is
that's
not,
true.
so it's automatically getting innervated by the urine flow, sir. It's automatically getting activated, stimulated
Stimulated
by the urine flow.
yes. Whenever urine distends the bladder, the spinal micturition center is stimulated and that sends efferent impulses that makes the bladder to contract. So the patient will pass urine automatically. So when the bladder is full, urine is empty. This is automatic bladder. In some people, what will happen is because of the upper motor neuron type of lesion, the external sphincter, which is a skeletal muscle, it becomes spastic. Spastic means it will always be under contraction. So even though when bladder is contracting, this should relax. This function normally will take place when complete micturition reflex is there. That means when the impulses are going to the brain, when the brain is sending the impulses, then spinal micturition center is working, then there will be synergy will be present. When upper motor center is knocked down, then the synergy is lost. So when the bladder is contracting, the external sphincter, instead of relaxing, doesn't go into relaxation, but instead it goes into rigidity. So it will always be in tonic contraction. So because of this tonic contraction, the bladder cannot empty properly. So that
Yes,
is called.
sir. One more thing, sir.
Yes.
Sir, in the, only the parasympathetic system, that is sacral outflow, it is being maintained just without any connection with the pons, sir. It is like their efferents are going from the bladder, they are going to the sacral center, and efferents are coming to the bladder again.
The sacral centers, the micturition is completely controlled by the pons or subpontine region. Micturition control means both the sympathetic as well as parasympathetic. Both will be controlled by the pons. Because the autonomic centers, they are situated in the basal ganglia region and in the pons region. So the impulses will come from the pons region. The parasympathetics also are controlled by that only. The sacral centers are there, which individually takes the response, just like any spinal center. The muscle is, for example, muscle reflex is there, biceps reflex is there. The reflex takes place only at the spinal center. Similarly, the micturition reflex also takes place at the sacral center. But that is under the influence of impulses coming from the pons.
Okay. Okay, sir, understood.
Okay.
Thank you so much.
Okay. Any more doubts, please? Someone has asked something to show the fistula, urinary fistula, isn't it? The first few slides. Shall I show them now? I didn't remember. Santhi or Shruti or someone has asked me. There was interruptions in the beginning, so she wanted to see those slides. Shruti, do you want to have the initial slides? I think Shruti is not here. It seems Shruti is not there. Okay, then I will close the session. Thank you very much. See you tomorrow.